Next, we'll try to connect with Valerie Smith. Valerie, are you on?
Yeah, I'm still here. She's still going, yes?
Good. So please state whether you're speaking on behalf of yourself or any other organization, and go right ahead.
Yes, hi. I am speaking on behalf of myself, and I am opposing this legislation.
Go right ahead.
Thank you. Thank you, Mr. Chairman and fellow senators. Thank you for allowing me this opportunity to speak to you about S593. My name is Valerie, and I was born in Seoul, South Korea in May 1988 with classical salt wasting congenital adrenal hyperplasia, CAH. Shortly following birth, I was put up for adoption. I would spend the first 8 months of my life not just in an orphanage, but also in a South Korean hospital. The reason for my frequent hospital visits as a baby was simply because the physicians at that time in South Korea did not know how to treat and manage my CAH. Because of that, the only way that the hospital could help me was to seek outside consultation from no other than Johns Hopkins Pediatrics in Baltimore, Maryland. It was a recommendation of my soon-to-be Johns Hopkins pediatric endocrinologist. The only way to keep me from constantly going into medical crises was for me to be put up for was to be adopted and brought to the United States, where they had better resources. Lucky for me, my mom-to-be heard about my CAH while working as a nurse in the Johns Hopkins Pediatric Endocrinology Department. Finally, at 8 months old, I'd be meeting my mom, my dad, and my 2 older sisters for the first time in December of 1988. I was not just privileged because I was adopted by such loving and nurturing parents here in the United States so quickly after being born, but also because my mom was a nurse and had a medical understanding and respect for my CAH, a privilege that many children, let alone CAH patients, do not have in this country. A few months after my arrival to my new family, I would undergo genital reconstructive surgery at Johns Hopkins, a single surgery procedure that involved clitoroplasty, vaginoplasty, and labioplasty. Fortunately, I cannot tell you how painful it was or how long my recovery was because I was less than 1 year old. But what I can tell you is that it was a successful surgery, a surgery that I am glad my parents decided to do when I was at such a young age. What makes the surgery a success for me is because I was able to live life like any other kid during this period of time. Because my surgery was done during infancy, I did not have to worry about any of my friends seeing me in a bathing suit during summer camp. I did not have to have additional insecurities about taking showers after middle school gym class. And most importantly, I did not have to worry about explaining to my teachers or my classmates why I would have to be out of school for an extended period of time because I was now 12 years old and now eligible to get reconstructive surgery. And let me be clear, the surgery I got when I was 9 months old does not, will not ever define who I am or my sexuality. My testimony is not an indication that I do not support the LGBTQ+ community or any person's right to assert their gender identity. My testimony is not to dismiss or to belittle anyone's thoughtful decision to undergo any kind of reconstructive surgery. But what my testimony is meant to do is shed light that there are successful congenital adrenal hyperplasia reconstructive surgeries out there. And if this bill were to pass, we would be taking away a safe and an effective choice to poor children and their family with CAH that I was so grateful to have been afforded. I would like to thank the members of this committee for listening. I'd like to thank my wonderful husband for his continuous love and support. And finally, I would like to thank my parents for having made this difficult and necessary decision on behalf of me and early in my life. Thank you. I'm open for questions.
I just have a question. Do you live in Rhode Island, or are you calling in from elsewhere?
No, I do live in Rhode Island. My number is still a Maryland number.
Okay. I was just curious how you heard about the legislation and got involved
Yeah,
in
I live in Rhode Island.
Okay, thank you. Any other
No worries.
questions for Valerie? I want to thank you for calling in and giving your personal perspective on the legislation.
Thank you.
I think finally on this bill, we're going to try to call into Wendy Becker. Wendy,
Yes,
are you calling in on behalf of Edgewood, or are you calling in on behalf of yourself or another entity?
always both.
Okay.
So thank you, Chair Miller and members of the committee. I want to start by saying that I'm glad the surgery and experience of the previous caller went well for them. I'm the chair of the undergrad social work department at Rhode Island College, where we strongly support this bill. We hope you will preserve bodily autonomy for children born with variations in their sex characteristics and protect them from non-medically needed surgeries without their consent. We feel that doctors should not be performing surgeries that can inflict permanent harm on children's physical and psychological well-being when they are simply too young to participate in the decision. The results can be harmful, the supposed benefit suspect, and the intervention irreversible. Forcing children born with atypical sex characteristics to have involuntary sterilization, involuntary genital surgery, infertility, and a forced sex assignment should not continue. Unnecessary intersex surgery is about doctors' discomfort with a child whose body differs from the doctor's rigid ideas about typical bodies and sex characteristics. It's the height of projection to be so uncomfortable with a person's body that you recommend performing life-altering, irreversible surgery and justify it by assuming the patient's discomfort. This bill places decisions about surgery until age 12, appropriately allowing time for the individual to consider whether surgery is right for them and what, if any, surgery they want. I hope you can work to amend the legislation centering the needs of intersex patients as you do this. So thank you very much, and I hope that this will pass out of committee and onto the floor.
You heard some of the testimony. Do you believe it's worth going back and actually engaging with some of the people that testified or who they represent on refining what procedures may or may not be defined in the legislation?
You know, I'm certainly not an expert on this, and there are people that are, so I hope that you can engage with them. I was concerned listening to the doctor's testimony as they seemed pretty closed off to having a conversation about compromise and making this bill better. And frankly, I think it's outrageous that we do surgery on people without their consent, and the fact that they couldn't acknowledge that fact was really problematic. Hopefully, stakeholders can come into the room and talk about it, but the needs of intersex people have to be what matters.
Right, and I think there's a way to kind of meet all those concerns based on engaging with people like the Medical Society and GLAAD to come up with language that is understood by several perspectives on this type of legislation.
Yes, and interact.
Okay, thank you.
I think that, yeah, thank you so much.
Okay, any other questions for Wendy? Thank you for calling in. I believe that's everybody on 593. I'm going to have Senator Valverde pick up some of the calls for a few callers, and we'll continue on other legislation.
Hi there, is this Beth?
This is
Hi, Beth. If you could just tell us what bill you're calling to testify on, or bill or bills, and if you are representing any organizations or yourself, and then you can go ahead with your testimony.
Hi there. I'm here in support of Senate Bills 484 and 430, and I am here representing myself and the American College of OBGYNs.
Great, go right ahead with your testimony.
Chairman Miller and the members of the Senate Health and Human Services Committee, I'm delighted to be here tonight. I am a practicing obstetrician gynecologist from Providence and here in full support of these two bills to provide improved care for the women of the state. As you know, in the United States, maternal mortality rates are among the highest in the developed world. In 2018, the CDC reported the maternal mortality rate to be 17.4 maternal deaths per 100,000 live births. Yearly in the U.S., about 700 women die during pregnancy or due to delivery complications per year. Current estimates show that up to half of the maternal mortalities in the U.S. could be prevented. We need to do more to help prevent these tragic losses. As you know, there are stark racial disparities in this maternal mortality crisis. The CDC data shows that Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women. Black women also suffer from life-threatening complications twice as often as white women. Risk factors for poor pregnancy outcomes, such as lack of access to care and health conditions, do not fully explain this racial disparity. More work definitely needs to be done to best identify the causes and to decrease the rates of morbidity and mortality. Well, some of that work is underway nationally and locally as we now have a state maternal mortality review committee. There are additional things we can do now. 2 of these things are being presented here tonight: providing Medicaid funding for doula support in pregnancy and extending Medicaid support for 12 months postpartum. Doulas provide emotional, information, and physical support before, during, and after birth for pregnant individuals and their partners. The goal is the doula and the family member work together as a support team for the patient. These doulas will provide care during labor, providing emotional support, comfort measures, and information and advocacy. I was very fortunate to be able to witness this firsthand in a very case that could have gone very differently. 6 months ago, I was a supervising OBGYN, supervising the residency service at the hospital, and we were fortunate to care for a patient who had gotten their prenatal care in Boston and was planning to deliver with a trusted obstetrician at a Boston hospital, but presented to women and infants with ruptured membranes as they were staying locally at the time. This individual has had many challenging interactions with medical professionals in the past, has had a large amount of distrust for the healthcare system. My team and I were able to work with them, their partner, and doula in order to build trust and navigate a prolonged, challenging labor course with a positive outcome, a healthy baby, and a happy family. Their doula was an invaluable asset to our team, continually available, unfortunately by FaceTime, as they were out of state. This was not due to COVID restrictions, but was because they were physically not here. Otherwise, they would have been planned to be present with this family. The doula helped this patient to weigh decisions night and day throughout many, many days in labor and helped the patient feel much more in control of a scary situation. Currently, Oregon, Indiana, Minnesota, and Nebraska have passed legislation for Medicaid coverage for doula support. There is some data that since doula support can contribute to decreased C-section rates, the doula care during birth has the potential for cost savings as well. It is time for Rhode Island to act to better support our pregnant individuals and help reduce maternal health disparities by having all insurances cover this in the state. To shift a bit to the Medicaid extension bill, this bill will ensure that Rhode Islanders who give birth while enrolled in Medicaid and Right Care will receive Medicaid coverage for 12 continuous months after delivery instead of the current standard 60-day postpartum coverage. As an OBGYN, I see day in and day out firsthand what happens when our patients no longer have access to full health coverage. We are very fortunate here that many of our patients do often remain eligible for Medicaid based on income, or those who don't qualify based on beyond the postpartum period may qualify for extended family planning coverage. However, that coverage only covers contraceptive visits and doesn't cover sterilization if that is what is desired by the patient. These women no longer have coverage for the management of substance use disorder, high blood pressure, diabetes, or perinatal depression and anxiety. As I've mentioned above previously, maternal mortality and morbidity is a huge crisis in our country. A recent study looking at etiologies of this demonstrated the 2 leading causes of death were cardiomyopathy and mental health conditions. both of which can be significantly better treated if patients have access to continuous, comprehensive, and affordable health coverage through the postpartum period. A year into the COVID-19 pandemic, the toll this has taken on my new mothers is apparent. The ability to refer my patients for ongoing mental health care as they have been able to maintain their Medicaid coverage up to this point has allowed me to ensure my patients are getting the support, treatment, care for postpartum depression and anxiety during this unprecedented time. Throughout the past year in Rhode Island, we have seen maternal deaths secondary to drug overdose in the postpartum period. Extended Medicaid coverage could help prevent these deaths by allowing patients to access substance use disorder care and treatment. Lastly, pregnancy also uncovers underlying medical conditions, such as mentioned diabetes and hypertension. To only be able to access care for these conditions while pregnant and 60 days postpartum leads these newly diagnosed conditions to be untreated and leads to lifelong poor outcomes. The American College of OBGYN supports the extension of Medicaid services to 1 year postpartum in order to provide this necessary health care and promote health equity. Addressing the health disparities evident in our maternal mortality crisis in this country requires a multi-pronged approach. Doula support in labor is a cost-effective way to provide women with additional support and advocacy and helps to improve outcomes. Both of these pieces of legislation will help us take steps towards helping to better tackle the maternal mortality crisis in this country. Rhode Island can be a leader in demonstrating that funding doula support in labor and extending Medicaid coverage through that 1 year postpartum period can allow continued access to care, which may improve outcomes and help save the lives of women. Tonight, I urge your support for both Senate Bills 430 and 484 to help protect Rhode Islanders. Thank you so much.
Thank you for your testimony. Are there any questions for Dr. Cronin from the committee? All right, I don't see any. Thanks so much for calling in.
Great, thank you.
All right, do we have Bethany?
Yes, that's me.
Hi, Bethany. If you could just tell us what bill you are calling in to testify on, and then you can go ahead with your testimony.
It's about the doula reimbursement bill.
Great, go right ahead.
Okay, so I'm the mother of 4 daughters. We live in Wakefield, and I wanted to speak in support of the doula reimbursement bill. Because we are a modern evidence-based society, we now increasingly understand that outcomes in birthing have a lot to do with the type of support around a woman when she is birthing. Does she feel safe enough, empowered enough, and free enough to allow the body to open? If the answer is yes, the chance of unanticipated medical interventions becomes dramatically less. I had 3 of my 4 children at home in what is usually called a natural birth, meaning free from pain medication. I had births that were honestly to dream for, where I felt empowered to do what I needed to do. They were loud and quiet, strong, gentle introductions to the world for these new little people who became my children. And while I do wish that I could brag about how strong this makes me, I do know in my heart of hearts that I was only able to do this because I could independently afford to hire the kind of support necessary to allow for this to happen. I could ensure that I had the right kind of support to feel safe and comfortable. Albeit to do this 4 times, my husband and I had to drain our savings and take from retirement funds. It was difficult, but we made it happen. My point is that we did have access to the money to be able to do so. Please, we cannot allow the type of birth that I was able to have to be mostly a luxury, one that only the affluent can ensure they have access to. The type of support a doula provides to a birthing person should not just be a luxury. It should absolutely be our standard of care for any person who is birthing in our community. This will save money, as we know it will lower birth complications. It will save anguish, as we know mental health outcomes from an event like birth improve when we have the right type of support. And it will move our community closer to equitable birth outcomes for Black and Brown moms. Ensuring that more women can access doula care is an excellent step toward being the type of community I'd be proud to bring my children up in. Thank you.
Thanks so much. Are there any questions for Bethany? All right, I don't see any. Thanks so much for calling in.
Thank you.
All right, I believe we have Courtney Hawkins with us.
Yes, Representative Valverde. This is Courtney Hawkins, Director of DHS. Thanks for the opportunity to testify tonight. I'm sorry to not be there in person. I wanted to offer my support tonight for the Child Care is Essential legislation that Senator Cano spoke about earlier. And again, appreciate the opportunity. I want to thank Senator Cano for her leadership on behalf of families in the child care workforce. I felt like it was especially important for me to testify on behalf of this bill tonight because I am so proud of the work that this sector has done over the past year during this challenging time. Our network of child care providers and their workforce have gone above and beyond to ensure that working families have had the care they need and that children have had safe and developmentally appropriate supports at a time that I would venture was probably some of the most crucial in our history. I also want to acknowledge the child care team at DHS who have gone above and beyond to support the sector over the past year. DHS and the Department of Health work hand in glove to promulgate detailed guidance and provide hours of technical assistance to help our providers to stay open. One of our primary goals has been to ensure the stability of the field during this time. We recognized how underfunded much of the sector was before COVID and how difficult this work has been. And as such, we rolled out a number of financial mitigations to support the field, including reimbursing providers based on enrollment and not attendance, waiving the allowable absence policy for CCAP children, waiving copays for CCAP children and covering the costs of these copays to providers, enhancing rates to support the increased costs associated with adhering to the regulations, and administering a $5 million recovery fund, which was a precursor to a now subsequent $18 million fund that will launch this week. It's my hope that this year we will build on these mitigations and further acknowledge that child care is essential to our state and that we need to make needed financial assessments as outlined in this bill. Expanded eligibility, caps on copays, increases to rates, and enhancements for infant-toddler care are all recognized as nationally established best practices that I believe are critical to our state's recovery. Rhode Island DHS stands prepared to take on the operational and technological implementation of these changes should the legislation pass this year. Thank you again for the opportunity to testify.
Thank you, Director, and thank you for all the great work that you and your team did before COVID and during COVID, and really appreciate you giving your perspective on this. Are there any questions from the committee? Senator Bell, go ahead.
Thank you so much. I just wanted to echo Vice Chair Valverde's comments. Thank you so much, Director Hawkins, for all the incredible work you've done to support our child care providers during this crisis. I've heard from many child care providers just how influential and life-saving for them those policies were. Particular, making sure that payments are based on enrollments, providing the increased rates. These were just such important services to continue for public health, for peace of mind for everyone in the state. And so thank you so much for all the work you've done.
Thank you, Senator.
All right, any other questions? Right. I don't see any. Thank you so much, Director.
Thank you.
Hi there, do we have Craig O'Connor?
Yes, hello.
Hi, Craig. Just let us know which bills you are testifying on and if you are representing any organizations, and then you can go ahead with your testimony.
Thank you very much, Chairwoman. My name is Craig O'Connor. I work for Planned Parenthood of Southern New England. I am testifying in support of two pieces of legislation today. The first is Senate Bill 484, which would extend doula services in Medicaid and private health insurance. Also here to testify in support of S430, which would extend postpartum Medicaid coverage for a full year. I have submitted written testimony, so I'm not going to go through everything that is in my written testimony. I just wanted to lift up a couple of quick points. The first, especially as regards the legislation for access to doula services, is this is a concrete step Rhode Island can take to address the maternal mortality and morbidity crisis that especially affects Black women and women of color. Black women are 4 times more likely to die from pregnancy-related causes than white women. Black women in the United States suffer life-threatening pregnancy complications twice as often as white women. This severe racial disparity cuts across income and education levels, socioeconomic status, and physical health conditions. This maternal mortality crisis is a symptom of structural racism, implicit bias, and racial inequity built into our healthcare system. And this manifests in specific ways, including provider bias and distrust, difference in treatment, and the physical impact of racism on the bodies of Black people and people of color, especially those who are pregnant. I highly encourage Rhode Island to move forward with coverage of doula services. I thank this committee and the Senate as a whole for having passed this legislation in the past. The last point I'd like to make on this particular policy proposal is we need to ensure that doulas, the providers themselves, do earn a fair wage. This is important work, and doulas deserve to be compensated in a way that is commensurate to the important role they are playing in the lives of so many patients. Switching gears to Senate Bill 430, around extending to a full year of coverage postpartum in Medicaid. Planned Parenthood, again, strongly supports that. We thank Senator Goodwin for putting in the legislation. We strongly hope that the committee will pass this. Much of what I was going to say has already been said. I think the one thing I'd like to add is sort of the perspective from the national level. There's a movement across the country to extend Medicaid postpartum coverage beyond the 60 days that some states have, including Rhode Island. This can be seen in a couple ways. Chairman Miller earlier mentioned that the American Rescue Plan Act of 2021 that was just passed includes a provision allowing states the option to extend postpartum Medicaid coverage for a full year. One drawback is this only lasts, this provision, for 5 years, and it is, of course, optional. We need to show leadership here in Rhode Island by making it permanent. I also do hope that at the national level, our delegation can support the Black Maternal Health Momnibus Act, which includes many different policy proposals to address the crisis in maternal, and in particular Black maternal health. I believe Rhode Island passing legislation will help lead the way to passing it for the full country. I appreciate you taking the time to listen. Oh, and I also want to say I am speaking not just on behalf of Planned Parenthood of Southern New England, but also on behalf of the Rhode Island Coalition for Reproductive Freedom, which is a group of 18 organizations working together to protect and expand access to reproductive health rights and justice. Again, thank you so much for having me today, and I'd be happy to answer questions.
Great. Thank you for your testimony, Craig. Are there any questions from the committee? I don't see any. Thanks so much. Have a good night.
You too.
All right. I believe we have Camille Williams with us.
Legislation will help lead the way.
Camille, are you there?
Hello. Yes, I'm here. Thank you.
Great. If you could let us know which bill you're testifying on and if you're representing any organizations, and then you can go ahead with your testimony.
Okay. Hello. My name is Camille Williams. I am representing the American College of Nurse Midwives, the Rhode Island chapter, as well as myself, and I'm calling to testify in favor of Senate Bill 484 and also 430. I did submit written testimony as well, so I'm not going to repeat everything that's in there, but I will say that the data is abundant and clear that doula support improves outcomes for mothers and babies. There's a Cochrane review of 22 clinical trials in 17 different countries that showed that continuous one-on-one labor support improves outcomes, including increased rates of spontaneous vaginal birth, shorter labors, decreased rates of C-section and instrumental vaginal birth, which is forceps and vacuum-assisted birth, also decreased use of pain medication and epidural anesthesia, fewer low 5-minute APGAR scores, which is a measure of newborn well-being, and fewer negative feelings about the childbirth experience. And there's also some evidence that the continuous labor support that doulas provide may result in lower rates of postpartum depression and preterm birth as well. And the unique thing about doula care is that most medical interventions will involve some calculation of benefit versus risk. And doula support is one of those few best practice care interventions that are it's consistently shown to improve health outcomes with absolutely no possibility of harm or risk to consider. And it's cost-effective as well. It would be the right thing to do if it were not cost-effective, but there is data showing that it is. And it sounds like the Chairman Miller, I'm very happy to have heard you say that the insurance companies are starting to recognize that. There was a 2016 study modeling the cost-effectiveness of Medicaid coverage for doula services, which found an average cost savings of $976 per birth. Even without that data, it stands to reason, just via common sense, that when a particular intervention is shown to decrease the numbers of all of those different medical interventions, that's going to translate into lower health care costs. And as has been mentioned by other care providers as well as consumers of maternal child health care, despite the well-documented health and cost benefits, doula support is essentially functioning as a boutique service for the privileged, and it's only accessible to people who have the financial means to pay many hundreds of dollars out of pocket. So as has been mentioned, it creates inequity, and it means that doula care is inaccessible to those who need it the most. Craig spoke at length about the racial disparities, and this is a very important way to address that. In addition to that, the way doula support is functioning in Rhode Island right now, it also marginalizes Black doulas because, they want to provide care to their own community. Culturally congruent care is the term that I've heard some of people in the birth community use. And there is felt pressure to provide care in a way that doesn't allow for them to support their own families in order to provide essential care to people in their own communities. So doulas deserve to be paid fairly, in addition to the fact that every pregnant patient deserves a doula if they want one. And I will just speak to, as midwives, what we experience. Our members of ACNM most of us attend births in the hospital, some of us at home. I attend birth in the hospital, and doulas are invaluable members of the healthcare team. Midwives, we actually pride ourselves